Good day. Welcome to the Immunochemistry lecture of the Biochemistry A. I am Dr. Geraldine Giron, and I am tasked to deliver this lecture, Immunochemistry. Before we start, this is a borrowed slide presentation by our late Dr. Rebecca Villanueva, a former faculty member at the Biochemistry and Nutrition Department in FUNRMF. So the outline of presentation would as follows: to discuss the properties and functions of the immune systems, and to describe the organs and cells in the immune systems, to differentiate the following: to also explain the events in the immune response, to discuss the antibody structure and diversity, and to explain the biochemical basis and types of hypersensitivity, autoimmunity, and immunodeficiency. Okay, first, let's discuss the properties and functions of the immune system. Generally speaking, the immune system has so many properties. These are the following. One would be specificity. What's the significance of for immunity to microbes? Now, specificity meaning it is the ability to recognize and respond to many different microbes. Okay, memory, on the other hand, is actually an enhanced responses to recurrent or persistent infections. Clonal expansion is the ability to keep pace with rapidly proliferating microbes. Specialization these are responses to distinct microbes that are optimized for defense against these microbial agents. Non-reactivity to self-antigens, on the other hand, this one would prevent injurious immune responses against host cells and tissues. After discussing its property and significance for immunity, let's discuss the roles of the immune system. The immune system actually, the main function of which is defense against infection. Now, how do we practice this? The deficient immunity results in increased susceptibility to infections. That's why we have this term immunodeficient. This is exemplified by AIDS, or the acquired immunodeficiency syndrome. Also, our body develops antibodies. So this defense against infections, one of the implications of that is vaccination. It boosts the immune defenses and it protects us against infections. Another role of the immune system is it recognizes and responds to tissue grafts and newly introduced proteins. Thus, these immune responses are very much important barriers to transplantation and gene therapy. Another role of immune system is defense not just against infections, but also against tumors. This role of the immune system has the potential for immunotherapy for cancer treatment. Lastly, the antibodies are highly specific reagents for detecting any class of molecules. Some laboratory testing approach is through immunology or serology. These are widely used now in clinical medicine and research as well as in vaccine development. Okay, next objective would be to describe the organs and cells involved in the immune system. Okay, we have three body's line of defense: the first, the second, and the third line. The first line would be called, generally, there are the tissue barriers. These are the skin, the mucous membrane, the stomach acid, and tears. Remember, the stomach acid, the acidity of the stomach is brought about by the production of hydrochloric acid by the parietal cells of the stomach. Parietal cells are the characteristic cells in our stomach. Okay? So these are the first line of defense. The second line of defense, generally we call this the phagocytes. No? These are the polymorphonuclear leukocytes, or what we know as your neutrophils. And also, phagocyte, meaning there are monocyte or macrophages. And we have different types of macrophages or macrophages in our body, which will be discussed in a little bit later. Okay? Example of a macrophage would be your Kupffer cells, which are found in our liver. And the third line of defense would be the B cells and the T cells. Now, generally, they are the cells of our immune system. The B cells would actually differentiate to become plasma cells to develop what's so-called antibodies. And the T cells have two types. You have the T helper and T cytotoxic cells, which will be discussed later. Okay, if we have cells, we also have organs of the immune system. We have the primary lymphoid organs and the secondary lymphoid organs. The primary lymphoid organs, they generally have this function as production and maturation. Bone marrow is a primary lymphoid organ, which is the site of production of most of the immune system cells. The thymus, on the other hand, is a site of maturation of the lymphocytes. They are only fully developed in children, and it usually regresses in adulthood. The secondary lymphoid organs function would be action and storage. One perfect example of a secondary lymphoid organ is our spleen. It is the site of storage of immune system cells, and they also recycle old red blood cells. That's why they are the site of RBC sequestration. Whenever the RBC matures after 120 days, senescent RBC will be stored and will be degraded in the spleen. Some of the lymphatic tissues are also considered as secondary lymphoid organs. These are the following: your lymph nodes, your tonsils, and your mucosa-associated lymphoid tissue or MALT. When we say MALT class, they are called mucosa-associated because this is actually a diffuse system of small lymphoid tissue that is found in the various membrane sites in our body. Example, our gastrointestinal tract. The whole small intestine, we actually have lymphoid tissues in there. But please take note that we have the so-called Peyer's patches, which is actually a lymphatic nodule found specifically at the lamina propria of our ileum. But in the duodenum and jejunum, we also have lymphatic tissues that are found in the lamina propria. The mucosa-associated lymphoid tissue can also be found in the thyroid, in the breast, lungs, salivary glands, eye, and the skin. Okay, so please take note the difference between the primary and secondary lymphoid organs. All right, these are the cells of the immune system. We have the effector cells and antigen-presenting cells. First, we have the effector cells. It is divided into lymphocytes, granulocytes, and phagocytes. And the antigen-presenting cells, they are just macrophages and dendritic cells. These cells will be discussed in detail after this slide. First, we have the effector cells, being its lymphocyte. There are two types of lymphocyte. We have the B and the T lymphocytes. Please take note that 15% of circulating lymphocytes in the peripheral blood are actually your B lymphocytes. They are generated in the blood marrow, and they are transformed or differentiated into plasma cells to produce antibodies, and this is called humoral immunity. When we say humoral immunity, this is called antibody-mediated immunity. No, with assistance of a T helper cells, B cells actually, or B lymphocyte, will be differentiated into plasma cells. That's why humoral immunity is also known as our antibody-mediated type of immunity. Okay, please take note, there are only 15% of the circulating lymphocyte. What makes up the majority of the lymphocytes in the circulation is or are your T lymphocytes. They are 70% of the circulating blood lymphocyte. And if your B lymphocyte are differentiated in the bone marrow, your T lymphocyte differentiate in the thymus. And if B lymphocyte is responsible for a humoral type of immunity, please also take note that the T lymphocyte is responsible for the cell-mediated immunity. Okay, and these T lymphocytes are classified by surface markers, and these are the cells: the CD4 or the T helper cells, and the CD8 are the cytotoxic T cells. Okay, the T helper cells or the CD4 accounts for 60% of the circulating T cells, whereas your CD8 cytotoxic T cells accounts for 30% of the circulating T cells. Okay, note the normal 2:1 ratio of CD4 to CD8 T cells is dramatically altered in some disease states, specifically if you are in immunodeficiency states such as HIV. Right. This illustration would just differentiate is generative lymphoid organs, which are your bone marrow and thymus, and your peripheral lymphoid organs, your lymph nodes, spleen, and your bone. Basically, if this is the bone marrow stem cell, this one will differentiate into two. You have the B lymphocyte and the T lymphocyte. If it is B lymphocyte lineage, it will go, usually the differentiation happens in the bone marrow. Now let's trace. After the B lymphocyte differentiates in the bone marrow, it will go here. It enters the blood. Sometimes it goes to the mouth or the peripheral lymphoid organs, and some of the B lymphocytes are then recirculated back to the blood. Okay. Next, from the bone marrow stem cell, when this bone marrow stem cell differentiated in the thymus, there are a T lymphocyte lineage. It will have its maturation there, and it will go to the blood and lymph. Just like your B lymphocyte, it will go to the peripheral lymphoid organs such as this, and it will be recirculated back again to the blood and lymph. Okay, after the third effector cells under the lymphocyte is actually the natural killer cells or the NK cells. They are also known as your granular lymphocytes or LGL because of their distinctive large size, pale cytoplasm, and prominent granulation. They are 15% of the circulating lymphocyte, just the same as your B lymphocyte. What does it do? They kill tumor cells, fungi, and virus-infected cells by the so-called antibody-dependent cell-mediated cytotoxicity. This is very unique to these natural killer cells. This is their mechanism in which immune system regulated by the natural killer cells, they do this antibody-dependent cell-mediated cytotoxicity. The natural killer cells actually are activated in response to interferons or cytokines. Now, cytokines are will be discussed further in a while, and the natural killer cells serve to contain viral infections. Okay, and they work to control the viral infections by secreting these interferons and factors such as cytokines. Okay, let's go now to the effector cells, granulocytes. From the word itself, granulocytes, they contain granules or specific granules. First would be the neutrophils or the polymorphonuclears or PMNs or your segmenters. This is the most common granulocyte. They release granules containing lytic enzymes such as lysozyme, and also they release reactive oxygen compounds. They are active during bacterial and fungal infections, but more of the bacterial infections. Usually, class, these neutrophils will be increased in bacterial infection. Okay, let's move on to the second granulocyte, which is your eosinophil. Your eosinophil is the major source of inflammatory mediators, such as your prostaglandins and leukotrienes. The eosinophils are active during allergic reactions, parasitic infections, as well as helminthic type of infections. Eosinophils. And lastly, your basophils. This is the least common granulocyte. They also release inflammatory mediators just like your eosinophils, and the basophils are actually active during allergic reactions. Okay? All right, so after the granulocytes, after the lymphocyte, let's go on to your phagocytes. But the macrophages are derived from monocytes together that they are called the mononuclear phagocyte system. Basically, their function is to engulf particles, internalize it, and eventually destroy them. We have different phagocytes of the monocyte macrophage series. The ones that we found in our brain is called your microglial cells. In the lungs, we have their alveolar macrophages known as your dust cell. In the liver, we call the macrophage as your Kupffer cells, while in the blood, they are called your monocyte. Also, not found in this illustration is a bone cell known as your osteoclast. Now, as discussed in your histology class by yours truly, osteoclasts are derived from the monocyte macrophage system, and their function is for bone resorption. Okay, let's go now to after effectors. We have the antigen presenting cells. They capture antigens for display to lymphocyte, or basically to present to lymphocytes. And these are our macrophages again in your dendritic cells. Your macrophages, they process and they present antigen to specifically CD4 T helper cells. Dendritic cells, they interact both with the T and B cells, and the dendritic cells in the skin are called your Langerhans cells. As discussed in the integumentary system histology, your Langerhans cells are a unique population of a tissue-resident macrophages found in our epidermis. Their location at the skin barrier suggests a key role as immune antigen-presenting cells. They are present technically in all layers of the epidermis, but they are most prominent in the stratum spinosum. Okay, in the stratum spinosum, you may find majority or prominent cells found in that layer or sublayer of epidermis. The stratum spinosum are your Langerhans cells. Okay. All right. So after knowing the cells, the lymphoid organs, the effectors, the antigen-presenting cells, let's now differentiate passive versus active immunity. Passive immunity meaning there is transfer of active immunity in the form of a ready-made antibodies. This can be a naturally occurring, naturally acquired, or artificial. When we say naturally acquired, perfect example of a passive immunity would be maternal antibodies via placental transfer or breastfeeding. No? And the other one would be the artificial, giving immunoglobulin or immunoglobulin administration such as rabies and tetanus immunoglobulin. These are preformed antibodies which when they are administered, you will receive passive type of immunity. Okay? And the active type of immunity will be there is stimulation of the immune system by means of an antigen or an infection that can be brought about by number one, naturally acquired. You had an infection. You acquired an infection by a microbe by all means of transmission or mode of transmission, and the other would be artificial. When we say artificial, active immunity, this can be brought about by injecting or administering live attenuated vaccines. These are substances that contain antigen. The live attenuated vaccines actually uses a living but weakened version of the virus or ones that's very similar. The most commonly available or routinely recommended vaccines worldwide would be MMR or the mumps, measles, rubella vaccine, your varicella vaccine, your rotavirus, and your influenza via intranasal. Okay, so meaning when you administer such vaccine, please take note if it is a preformed immunoglobulin or they contain antigen. All right, so after differentiating passive from active, let's now move on to differentiate an innate type of immunity versus an adoptive type of immunity. These are the properties, and we will be differentiating innate from adoptive immunity by these properties. Now, one would be the physical barriers. In innate immunity, we use skin or mucous membrane, whereas in adoptive immunity, there's none. The cells found in the innate immunity would be the antigen-presenting cells, your granulocytes, your phagocytes, and your natural killer cells. Whereas your adoptive immunity, aside from natural killer cells, majority of the cells in the adoptive immunity would include your T and your B lymphocytes. Okay, please take note of this. Soluble factors found in the innate immunity would be the enzymes, your lysozymes or the complement proteins, your complement systems will be discussed further in a while, and your C-reactive protein. Adoptive immunity would be antibodies and lymphocytes. Okay, in terms of memory, memory is only exhibited by your adoptive type of immunity. Okay? Okay, this illustration would differentiate innate from adoptive immunity. Now, please listen. When it comes to specificity, for structures in the innate immunity, they are shared by classes of microbes with what we call your molecular patterns. If you notice in this illustration, these cells in the innate immunity, they have identical mannose receptors, but take note, they have different microbes. So they share classes of microbes, but they have an identical receptor for all these cells in the innate immunity. Look at the adaptive immunity. For structural detail of a microbial molecules or antigens, they may actually recognize non-microbial antigens. As opposed to your innate immunity, in the adaptive type of immunity, for the different microbes, they have distinct antibody molecules. Okay? They have a distinct antibody molecules for the different microbes, as opposed to your innate immunity, which has a different microbes, identical mannose receptors. Okay, what else? When it comes to your receptors, innate immunity, they are encoded in germline, or they have limited diversity, as opposed to your adaptive immunity, which are encoded by genes that are produced by recombination of gene segments, and thus they provide us a greater diversity. Now, as opposed to innate immunity, which has limited diversity. For the distribution of receptors, innate immunity are usually non-clonal, meaning identical receptors on all cells of the same lineage. Whereas in the adoptive immunity or clonal, there are clones of lymphocyte with distinct specificities expressing different type of receptors. Okay. And lastly, the discrimination of self and non-self, they're actually both exhibited by innate and adoptive immunity. In the innate immunity, the host cells are not recognized, or they may express molecules that prevent innate immune reactions, whereas in the adoptive type of immunity, they base on the selection against self-reactive lymphocyte. So if this self-reactive lymphocyte becomes imperfect or deranged, that will give rise to autoimmunity, meaning it attacks your own self. No, you cannot differentiate an infection to your host cell per se. So that will give rise to autoimmunity. And we have different types of autoimmune disorders, which will be discussed later in this presentation. Okay. All right. So this is just an illustration of your innate and adoptive immunity when you have an infection. During the first 6 to 12 hours, our innate immunity provides us immunity. No? These are your epithelial cells, your phagocytes, your complement system, your complement proteins, and your natural killer cells. But when the time comes that these microbes underwent innate immunity, after 12 hours, usually the adoptive immunity would take place. The time duration would be from 1 day to 5 days to 7 days to 1 month, depends. So in the adoptive immunity, it is exhibited by the presence of your B lymphocyte. As discussed earlier, they will be differentiated into plasma cells, giving us antibodies. Your T lymphocytes, on the other hand, would become an effector T cells. And this one, once they B lymphocyte and T lymphocytes proliferate, we are at the adoptive type of immunity. Okay. Now, after differentiating those types of immunity, we'll also have another differentiating terms in immune system. You have the humoral or cell-mediated type of immunity. The humoral immunity, and this one is the cell-mediated immunity. This illustration would actually help you or guide you in understanding immunochemistry. No? Once microbe, enters our body, humoral immunity, if there are extracellular microbes, meaning they are not inside. That's the term extracellular. But when the time that these microbes enters into macrophage, meaning there is phagocytized microbe in the macrophages, or there are intracellular microbes such as viruses replicating already within the infected cells, you are at the cell-mediated immunity. Okay? Another differentiating would be the responding lymphocytes. In humoral type of immunity, B lymphocytes, specifically the differentiated B lymphocyte known as your plasma cells, will be secreting antibodies. And that will be the effector mechanism of your humoral immunity. Let's compare this to your cell-mediated immunity. In the cell-mediated immunity, depends on what type of T cell are involved. And when you say helper T cell or the T lymphocyte, as exhibited by CD4, the function of these T helper cells will just activate these macrophages to kill the phagocytized microbes. Whereas in this area, another cell-mediated immunity cell would be the T cytolytic or cytotoxic cells, exhibited by CD8. They will kill infected cells and they will eliminate the reservoir of infection. So basically, in generally speaking, in summary, T lymphocytes, cell-mediated immunity, whereas your B lymphocyte, their antibody-mediated type is your humoral immunity. Okay? All right, so this is just another illustration on how to study this humoral immune response and cell-mediated immune response. Now look, on the first exposure of the antigen, sometimes they will be stimulating already the B cell, and they directly activating T cytotoxic cell. Okay? But also, during this antigen first exposure, as engulfed by the macrophages, it becomes an antigen-presenting cell. The antigen-presenting cell will only present this macrophage-engulfed antigen in T helper cell. Please take note of this. Now, if the antigen first exposure directly activate T cell and T cytotoxic cell, the T helper cell will be presented first the virus, the macrophage or the antigen presenting cells is stimulating this T helper cell. All right. How else can we stimulate the B cell and your T cell? By means of this T helper cell. Once T helper cell activates, it stimulates both the B cell and your T cytotoxic cells. Okay. Now next, T cell will be differentiated into memory T cell. Okay, memory T cell. But individually speaking, B cell will give rise to memory B cells as well. But the main function of your B cell is that they will be differentiated into to become plasma cell, which will secrete eventually your antibodies. Now they will neutralize the toxins and viruses, and they opsonize bacteria for easier phagocytosis. While your T cytotoxic cell will give rise to, number one, memory T cells and an active cytotoxic cells. This one would function as killing your intracellular pathogens. But look, when there is antigen or second exposure to the antigen, number one, it will stimulate directly the memory T cell. By stimulating the memory T cell, it will then activate or stimulate this B memory cell and these memory T cells, and then their functions will now be exhibited as whether the first exposure to antigen or second exposure to antigen take place. Okay, so in this phase, this one will be activation phase, and this one will be the effector phase based on the type of exposure and what blood or what cell or effector cells will be used. Okay. Okay, so as mentioned a while ago, so many times, let's differentiate a B cell and T cell. So basically, the properties such as your specific antigen receptor, your B cells being, they provide antibodies, so they are their surface immunoglobulin. Immunoglobulin is also known as your antibodies. In your T cell naman would be T cell antigen receptor, or T cell antigen receptor. That's the specific antigen receptor. For antigen recognized, sometimes the B cell would be in intact antigens in native conformation, 3D nonlinear, both free and on cell surface. While your T cell would be your processed peptides, linear or surface of cells in association with your MHC molecule or your major histocompatibility complex molecule, which will be discussed later. All right, so basically, again, let's differentiate in the immunochemistry a primary versus immunity or versus secondary humoral response. Okay, when you say humoral response, this is exhibited by the production of antibodies. All right, so this is actually a good illustration taken by Basic Immunology book. Look at this one. This is the student serum antibody titer, and this is the duration of the infection. Right, look at this legend. This is your naive B cells. This is your pre-antigen exposure. Right, so this is the X and this is the Y. Okay, if there is introduction or exposure to antigen X, what would be activated would be the activated B cell X. No? This is exhibited by the purple in color antibodies. What would happen is that after activation of B cells, as previously discussed, this will become antibodies or it will become your memory B cells, right? What about the green ones, the anti-Y? Since they don't have antigen Y yet, this B cell anti-Y is the same. No, they will not be activated, and they will not become memory B cell. But okay, in some time after this duration, third week, there is a reintroduction of your antigen X, reintroduction or re-exposure, and there will be a first-time exposure to your antigen Y. Okay, what would happen? There is a secondary response to your antigen X B cell. This will be activated again, B cells. But what about this naive B cell? Since there is a first introduction to an antigen Y, these green ones will have a primary anti-Y response. And eventually, after this activation of the primary response, there will now become a memory B cell, specifically with antigen Y. Okay, so if there is a reintroduction and there is a first-time exposure to antigen, the first antibody will have a secondary anti-X response, which eventually will have elevated levels of antibody titers compared to your first antibody or first response to the antigen Y, which only exhibits primary anti-Y response. Okay, so please take note, there is a primary and secondary response, and this will based on the reintroduction of your antigen or re-exposure or a first-time encounter to such antigen. Okay. All right. So, clonal selection is actually stating that B cells express antigen-specific receptors before an antigens are ever encountered in our body. So, this actually explains why this primary or secondary immune responses from the memory cells are so effective that when you have a repeated infections or reinfections by the same pathogens, they are already stopped before symptoms even occur or develop. Now, this is what we call your clonal selection. In this illustration, this is the lymphocyte precursor. This is a mature lymphocyte, another lymphocyte, and another lymphocyte. This lymphocyte clones mature in generative lymphoid organs in their either in your bone marrow or your thymus in the absence of antigens. Wala pang antigens, meron ng clonal of your T lymphocytes. What does it do? These clones of mature lymphocytes, specifically for diverse antigens, will enter lymphoid tissues. Okay? Once there is introduction to a specific antigens, let's take, for example, an antigen X, and here is antigen Y, there is now an antigen-specific clones that are activated by your antigens. Meaning, there will be an antigen-specific immune responses occurring already. So this is the this actually also explains why vaccines work. No, we have a preformed antibodies just like this, that whenever we encounter an infection or exposed to such infection, we are actually protected already. We already have antibody. But in the clonal selection, before antigen is present, we don't have yet antibodies, but we have an effector cells ready to be in contact with an antigen as the need arises. Okay. All right. So now let's explain the events in immune response in immunochemistry. But first, let's define some terms. We have antigenicity or your specific reactivity and immunogenicity. We as we all know, the word antigen, antibody, immune system are very much common right now because of the COVID-19 global pandemic. But what is really an antigenicity and immunogenicity? How do we use these terms? Now, antigenicity or specific reactivity is the property of a substance, which is an antigen, that will cause it to react or bind specifically with an antibody or a cell. So basically, if there is an antigen antibody or antigen cell encounter, it's called antigenicity, specific reactivity. But what about immunogenicity? This is the ability of the substance or immunogen to induce a specific immune response, resulting to a formation of antibodies or immune lymphocyte. So basically, now remember, immunogenic substances are always antigenic, all right? But antigens are not necessarily immunogenic. I guess that's based on the definition of antigenicity and immunogenicity as opposed or as in the context of immunochemistry. Okay, please remember those terms. Okay, another definition of terms, we have haptens and epitopes. As the name implies, we say haptens, they are partial antigens that are antigenic, but they are not immunogenic. Example would be the 2,4-dinitrophenol or your penicillin. Okay, your epitopes, on the other hand, these are antigenic determinants. They are parts of antigen molecule to which a cell or an antibody attaches itself. So one antigen can have multiple epitopes depending on their antigenic determinant. So epitopes ay nandun sila sa antigen at there are so many epitopes in one antigen. Okay, let's talk about Bcell activation and T-cell activation. You've been hearing this differentiation a lot of times. So this one is your T helper cell. As mentioned, the T helper cell stimulates your B cell, and the B cell will proliferate and differentiate into two. We have the B cell as your memory B cell, and the other one would be the B cell differentiating into a plasma cell. Please take note, look at the description of the plasma cell histologically. Your plasma cells, as described in the histology of connective system, connective tissue, they appear as spokes wheel or cartwheel in appearance, thus producing your antibodies. So they are derived from your B cell. How about your T helper cell? Now, from the antigen presenting cells, as mentioned, the T helper cell will only be activated once there is an antigen presenting cells, meaning there are virus that engulfed by these antigen presenting cells is stimulating this T helper cell. Now, once activated, it will become number one, T cell. It will again proliferate as your T cell, T helper cell. And lastly, this T helper cell would immediately release cytokines and other growth and differentiation factors. Okay. All right, this is just an illustration of the capture, processing, and presentation of an antigen by an antigen presenting cell. So this one is the immunogen. This is your macrophage or an antigen presenting cells. Once engulfed, they would produce this endosomal, lysosomal function. No, they engulf, they lyse, and then they will be producing MHC2. MHC2 is a major histocompatibility complex 2, and that one will be mag-a-appear sila dun sa cell ng antigen presenting cell providing your T cell receptor. Once this MHC2 binds to the T helper cell only, because this is unique to a T helper cell, MHC2, thus this is the process of presenting the virus by an antigen presenting cell to the T helper cell, not by the T cytotoxic cell, not T helper immunogenic. Okay. So let's talk about the human leukocyte antigen or the HLA system. This consists of group of related proteins localized to a region on the short arm of chromosome 6, and that is known as your major histocompatibility complex or MHC. Now, the HLA is important in organ transplantation, where HLA typing and matching of donor and recipient are now widely used to predict tissue compatibility. Now, worldwide, what do you think are the most commonly transplanted organs? Now, according to the the CDC or the Center for Disease Control in the US, the most commonly transplanted organs are the kidneys, the liver, the heart, the lungs, the pancreas, and the intestines. But in the organ which has the highest success rate in transplantation would be kidneys. Okay, they have the greatest success among all the procedures in transplantation, and just like in 2019, the kidney transplant were the most common, followed by liver, heart, and the lungs. No, but what I'm trying to say is the HLA system, we actually use this both on the donor and the recipient. Now, this is very much important to predict the tissue compatibility of the organ to be transplanted. Even if you are brothers, sisters, friends, you have to undergo series of tests before the actual transplantation takes place. Okay? All right, so let's compare the class 1 and class 2 MHC molecules. So in the molecules included in class 1 would be the HLA A, B, and C, while your class 2 would be your HLA BP, DQ, DR. Okay, the functions. When we say HLA or MHC class 1, they present processed antigenic fragments to CD8 T cells. They restrict cell-mediated cytolysis of virus-infected cells, and usually the cell distribution of class 1 would be ubiquitous or present in everywhere on virtually every somatic cells. When as opposed to class 2, they present the processed antigenic fragments to your CD4 T cells. In class 1, it's CD8. In class 2, it's CD4. They are necessary for an effective interaction among immunocompetent cells. And take note of this, the cell distribution of your class 2 is only restricted to immunocompetent cells, such as your B cells and macrophages, B cells and macrophages. Immunocompetent cells lang sila restricted when it comes to class 2 or MHC class 2. Okay? And these are the associated disease with HLA antigen. Please take note of this slide. No? HLA B27, specifically B27, is found in 90% of the cases of ankylosing spondylitis. This is a condition in which the spine and the other areas of the body become inflamed. Usually, this ankylosing spondylitis first developed in teenage years and young adults, and it's usually 2 times more common in men than in women. Okay, that's your HLA B27 defect. HLA DR4 is what associated diseases would be rheumatoid arthritis and type 1 diabetes mellitus. Your HLA DR2 or DR3, that is your systemic lupus erythematosus, which is the most common type of lupus. It's an autoimmune disease in which immune system attacks its own tissues, as the name implies, autoimmune, causing widespread inflammation and tissue damage in affected organs, usually at the joints, skin, brain, lungs, kidneys, and blood vessels. So this is not common, but it's a rare autoimmune disease. But it's common now among Filipinos, and usually if you presented with a signs and symptoms of lupus or systemic lupus erythematosus, you usually have to refer that to a rheumatologist, and sometimes this rheumatologist refer this to a cardiologist, dermatologist, pulmonologist. So it's a multifactorial symptoms, thus needing a multi-specialty approach. Okay, in the advent of COVID-19, these are actually one of the terms that doctors use when we treat or when we diagnose COVID-19, right? So the cytokines are soluble proteins secreted by lymphocytes. That's your lymphokines, or sometimes by your monocyte macrophage or your monokines, your natural killer cells, and other cell types. Now, they act as an effector molecules by influencing behavior of different cell types. Now, we have different cytokines and their functions. Now, please take note of this table. We have their interleukin-1, now the source of which are your monocytes and macrophages, and their function is to stimulate your T cell proliferation and interleukin-2 production. Your interferons, such as your alpha, your beta, and your gamma, they differentiate based on the source of these interferons, but they are all antiviral. Okay, the B cells or the macrophages are only at the alpha interferon. Your fibroblast or the parenchyma of your connective tissue is actually an example of a beta interferon, or comes from fibroblast, the beta interferon, and the gamma interferon will be coming from the T cells. Take note, they are all antiviral. Thus, this we are talking about cytokine storm. COVID-19, as you all know, is a viral infection. So as DOH recommends that there will be no antibiotic use. In COVID pneumonia, sometimes there is a concomitant bacterial infection of a COVID type of pneumonia or a bacterial pneumonia. Thus, antibiotic use is being recommended. But for now, one of the diagnostic tools in COVID-19, when you are in the emergency hospital and you are suspecting this patient has COVID, since the pathophysiology of COVID is a cytokine storm, one of the diagnostic tools are actually your tumor necrosis factor, interferon. These are all cytokines because cytokine storm is the mechanism why COVID-19 proliferates in our body. Okay? And the last cytokines would be your TNF or your tumor necrosis factor. You have your TNF alpha or your cachectin and your tumor TFN beta. Now, they're all from the macrophages, and their function is to stimulate the T cell proliferation and interleukin-2 production and they are cytotoxic to some tumor cells. Thus, the term tumor necrosis factor. As you all know, when you say lymphocytes, we are dealing with viral infection. And one of the management for viral infection is actually supportive treatment, not antibiotics. All right. Okay, we also have these colony-stimulating factors, which directs the division and differentiation of the bone marrow stem cells and the precursors of the blood leukocytes. Okay. All right. So, immunochemistry, we have to find out what are the mechanisms on eliminating antigen in our body. No? In this illustration, we all know that B cells produce antibodies. Now, what are the mechanisms on eliminating antigen by producing an antibodies? Now, number one would be phagocyte. Now, they neutralize your microbes and toxins. And also, being a phagocyte, it opsonized and phagocytized your microbes. Now, thus, helping our body to eliminate those offending agents. What else? By natural killer cells. The natural killer cells, as you all know, eliminates antigen by the use of the antibody-dependent cellular cytotoxicity. Okay? And lastly, look, because of the complement system or the complement activation. As will be discussed in a little while, this complement activation depends on the complement factors, right? So it can lyse your microbes, it can involve in phagocytosis of the microbes, and it involves your inflammation. And the membrane attack complex, that's the product of our complement activation. And there you go. You have your complement system. Now, it consists of about 20 plasma proteins and their products, which can be activated by the way of the classical or alternative pathway to form a final product, as I mentioned, the membrane attack complex. And that's the final product, MAC, and the function of that is to lyse the targeted cells. Right? And we have two. You have the classical and you have the alternative pathway. So what's the difference of the classical and alternative? The classic pathway is initiated by the reaction with antigen-antibody complexes, right? While the final lytic form of the activated complement is the result of a series of enzymatic cleavages and recombination of these cleavage products. Now, I will be showing you an illustration differentiating the classic and the alternative pathway. On the other hand, the alternative pathway is initiated directly by non-immunologic stimuli, such as invading microorganisms, and like the classic pathway, that will lead to cleavage products that cause cell lysis. It actually bypasses the initial stages of the classic pathway. So let's see. All right, so this is your complement system. This is your classic pathway and your alternative pathway. The classic pathway is exhibited by this one, the antigen-antibody complex. It will activate C1. Once activated, the C4 and C2, because of this activated C1, will be converted to C3 convertase of the classic pathway. That's your C4B2A. A C4B2A. Now look at the alternative pathway. There is no antigen-antibody complexes. What is present here is your C3b na. No? C3b is actually induced by a microbial surfaces polysaccharides, and it is brought about by a factor with the factor B and factor D, as seen here in the illustration. It will become now your C3b3b. C3bbb, that's your C3 convertase, but that's stabilized by property by the alternative pathway. Now look at the difference. That C3 convertase of the classic could be the C4B2A, while the C3 convertase of your alternative would be the C3B. Once they are activated, they will activate the C3 to become number one, C3A. And what does that mean? C3A is actually an anaphylatoxin. It induces inflammation. Okay? What about your C3B? Your C3B, on the other hand, will become opsonin. This opsonin helps you convert your C3 to C5 in both classical and in alternative pathway. So this C3b opsonin as well as this convertase producing the C5 convertase such as this one would help you converting this C5 to become the following. Number one is C5a. Just like C3a, they will become our anaphylatoxins. When we say anaphylatoxins, they involve in vasodilation, vascular permeability, and they are also generated via plasmine or lysosomal proteases. That's the C3a, that's the product. C3a and C5a, they're anaphylatoxins. What about C5b, though? C5b with including the C6, C7, C8, and C9, collectively they're called your C5, C5 to 9. That is your membrane attack complex. And this is the final product of your complement system, meaning they will lyse the targeted cell, right? So in here, what is shown in this illustration is that this one is the complement facilitating phagocytosis. No? These are the C3, C3b to C3b opsonin. Now in this slide, please take note of the important complements. No? C1 would initiates classic pathway, while your C3 initiates your alternative pathway. C3a is responsible for inflammation, while your C3b is responsible for opsonization and phagocytosis. Opsonin. C5 would initiate chemotaxis, while your C5, C6, C7, and C8 and C9 would constitute the membrane attack complex, lysing or targeting the target cell. Okay? So that is our complement system. The classic and alternative, please take note of the anaphylatoxins, C3 and C3b, what are their roles, and what constitute the membrane attack complex would be the C5 to C9 membrane attack complex. Okay, that's the final product of your complement system. Okay, so I've been mentioning antibodies because of this B cell proliferation and differentiation. Let's talk about the antibody structure itself. Now, antibodies are glycoproteins. Now, they specifically globin proteins that react with antigens, thus having an antigen-antibody complex. They make up 20% of the protein in the blood plasma, and we have 5 classes. We have IgG, IgA, M, D, and E. But before we differentiate the 5 classes of antibodies, let's discuss the structure of the antibodies. Okay, we have light and heavy chains, polypeptide chains that are held together as a tetramer by disulfide bonds. So the L chains or the light chains consist of your one variable and your one constant domain. So VL, V meaning variable light and constant light. While most heavy chains consist of one variable, that's your variable heavy, and 3 constant. You have the CH or the constant heavy. There is what we call your FAB region and the FC region. Papakita natin doon mamaya. The FAB region is also known as your fragment antigen binding. And this includes your VL, your CL, your VH, and the first CH or the constant heavy. They determine the antigen binding specificity. While your FC region is a fragment crystallizable, they consist the rest of the constant heavy and they determine the antibody's class effect. So let's discuss first these two, the FAB region and the FC region. In the FAB region here, the FAB or here, kahit saan, this includes the VL. This is the light chain class. We have the variable and constant. And this is the heavy chain. We have the variable, constant, and tatlong constant heavy. Usually CH1, 2, and 3. Now, the FAB region, this is the fragment antigen binding site. Now, this determines the antigen binding specificity. And this includes your VL, your CL, your VH, and the first CH1. Okay, so technically, this one is the whole FAB region. This is disulfide bonds and also disulfide bonds. Okay. What about your fragment crystallizable, your FC region here? The FC region here, from the definition, consists of the rest of the CH and it determines the antibodies class effect. This one is your FC region. Okay? The rest of the CH, that's the CH2 and CH3, depending on the immunoglobulin structure. So, ito po ang magdetermine ng antibody class. So, this is just an example of an IgG and an IgM. If you look at this FC region compared to your IgM, this one class, no, this determines the antibody class because of this FC region, but they have the same antigen binding site or Fab region. Okay, so this FAB or the antigen binding site is composed of 4, while the rest of the CH2, 3, and 4, this one is 2, 3, this will determine the antibody class. That's the FC region. All right, so this is just a table showing you the different types of antibodies. If you look at this table, what you will notice is that the serum concentration, okay, obviously the serum half-life in days, the highest is your IgG, right? And this IgG is the use or its function is for opsonization, complement activation, and very important, neonatal passive immunity through placental transfer. So this is the most common antibody seen in placenta or in placental transfer. What about IgA? No, let's take a look at the IgA. The IgA is actually a dimer, IgA dimer. They are involved in the neonatal passive immunity through breastfeeding. IgA kasi is a secretory immunoglobulin. So all secretions, IgA are present, specifically at your breast milk. So sabi nila, in pediatrics, breastfeeding is best for babies until 2 to 3 years old. Why? Because they have antibodies. So at the end of this lecture, don't just tell your mommy, your tita, your relatives that it's just plain antibody. You have to take note that specifically they are the secretory antibodies or your IgA. Okay? Now, what about IgM? Yeah, this is the antibody present in an active or an acute infection. And this is the only antibody which is a pentamer. Okay? This is a pentamer. Okay. Now, let's move on to the different biochemical basis of hypersensitivity. So when we are talking about immunochemistry, because of the initial response, so dapat merong exposure. Okay? And now these are the two phases of hypersensitivity reaction. We have exposure and re-exposure. So imagine in our entire life, we had an allergy, no? Rashes, wheals because of a allergen, no? With this antigen or allergen will be presented to the APC, and as I've mentioned a while ago, this processed allergen inside the antigen presenting cell will stimulate the CD4 T cell, right? CD4 lang. This CD4 T cell on the first exposure will be stimulating the B cell to promote or to differentiate to plasma cell. So you already have antibodies against the first exposure. And the other differentiation of the T cell will be just the T cell effector. So meaning that's the first exposure. Whenever there is a re-exposure, you are entering on the effector phase na. Okay? So they have different mechanism. We have 3. Allergen and the re-exposure. No, after recognizing this allergen, you have an antibody called your IgE antibody, which are present in mast cell. What does it do? It mediates the release of antihistamine. Oh, sorry, the release of histamine. The histamine would produce or would its functions are to smooth muscular contraction, arteriolar dilatation, and vascular permeability. So meaning, these three mechanisms, they all involve in the inflammation process of your hypersensitivity reaction. Okay. Another mechanism is that there is an immune complex with IgG antibody. Okay. With this antigen antibody complex, such as activating your complement, they will produce anaphylatoxins or chemotactic factors, which will eventually lead to inflammation as well. And the last mechanism during re-exposure would be directly affecting the effector cells, releasing the lymphokines or cytokines, thus involved in the inflammation. All right, so these are the mechanism of hypersensitivity reaction. And we have 4 types. Now let's discuss this one by one. Your type 1 is also known as your anaphylactic. No, the antigens, they just react with IgE bound to the surface of the mast cells, causing degranulation of this release of histamine. So in this type of hypersensitivity reaction, example would be hay fever, asthma, allergy, hives, and when it is left untreated, this type 1 anaphylactic hypersensitivity reaction would produce anaphylactic shock. Okay, so basically there is allergen reacting to IgE-bound cells in the mast cells, kaya magde-degranulate siya, lalabas na yung histamine. And the treatment for this is antihistamine. Okay? All right, next. Type 2 would be cytotoxic. The antibodies here react with antigen in the cell membrane or at the basement membrane. Example of the cytotoxic reaction or type 2 would be the HDN or the hemolytic disease of the newborn or the ABO incompatibility, meaning cell na yung tina-target niya. Type 3 would be the immune complex. The antigen antibody complexes are deposited in the vessel wall and other substances. Thus, the most common example of your type 3 hypersensitivity reactions are your serum sickness, your SLE, affecting every organ in our body, and other autoimmune diseases. No? When it comes to an immune complex, isipin nyo agad, you think of an antigen-antibody complexes. And type 4 would be cell-mediated. In the cell-mediated hypersensitivity reaction, also known as your delayed hypersensitivity reaction. So as illustrated here, when there is an antigen, there is cytokine secretion. When this cytokine secretion, as you all know, cytokines can cause inflammation, there's cellular infiltration and swelling, thus producing a type 4 cell-mediated hypersensitivity reaction. Example of type 4 are your tuberculin reaction or tuberculin skin test and your contact dermatitis. Okay, so please take note of the different types of hypersensitivity reaction, their other names, their mechanisms, and the examples of each type. All right, so let's move on. So after hypersensitivity reaction, let's go now to biochemical basis of autoimmune disorders. When we say autoimmunity, this results to diseases caused by immune reactions directed towards the tissues of the host, with apparent inability to distinguish self to non-self. Okay, so basically in autoimmune diseases, there are 2 types of immune response. It's either the receptors or the cell components. Now, in the receptors and antibody to receptors, there are different diseases and they have different targets as well. The myasthenia gravis, that's the first example of an autoimmune disease, targets your acetylcholine receptors. Your Graves' disease is an example of in hyperthyroidism, wherein there is a chronic stimulation of your TSH receptors, producing a hypersecretion of your T3 and T4, which are your hormones in the thyroid. So producing a hyperthyroidism. So this is an autoimmune chronic stimulation of your thyroid. Kasi nga ang target are your TSH receptors. Type 1 DM is its target is your insulin receptors. If you don't have if there are if it targets your insulin receptors, the level of your insulin will also be affected. No, if there is an increased level of sugar or glucose in your serum, there will be no insulin that is secreted by the pancreas, thus producing type 1 TM. Okay, there is a beta autoimmune destruction of your beta cells as well as your insulin receptors. In the Lambert-Eaton disease, there is a calcium channel receptor. That's the target of your Lambert-Eaton disease. So these are the antibody 2 receptors. Let's go now to antibody 2 specific cell component. Your SLE, this double-stranded DNA, that's the target. Your rheumatoid arthritis, IgG in joints. Your rheumatic fever, not just the joints, but also this one would this one would actually involve the rheumatic heart disease. ITP, or the idiopathic thrombocytopenic purpura, its target is actually platelets. No, I've encountered one patient wherein the patient, this 2-year-old female presenting with purpura or rashes, came to the outpatient department and with no other signs and symptoms, just rashes. So when we requested a complete blood count, it turned out all are normal except for the platelet. Her platelet count is just 4,000. The normal value is 150,000 to 450,000. So this patient, without any symptoms, just the purpura or the rashes, was brought to the Philippine Children's Medical Center and was admitted at the ICU initially. No, she was hydrated. She was referred to hematologist, and she was later presented to the whole hospital as a case conference as a case of an ITP, an idiopathic thrombocytopenic. Thrombocytopenic meaning you have a low level of your platelet count, just like in any other viral exanthem, such as your dengue, your measles, etc. Okay. Another autoimmune is actually your pernicious type of anemia. Now, its target cells are your parietal cells of the stomach. The parietal cells are actually our characteristic cells of the stomach producing your intrinsic factor. Now, the intrinsic factor is actually important in vitamin B12 deficiency, in vitamin B12 absorption. Now, if you don't have intrinsic factor, vitamin B12 will be poorly reabsorbed, thus producing a megaloblastic type of anemia in a form of pernicious type of anemia. Okay. Another autoimmune disease is your Goodpasture syndrome. Its target cells are your basement membrane cells of the kidneys as well as your lungs. And we have Hashimoto's thyroiditis. If your Graves' disease targets your TSH receptors, your Hashimoto's thyroiditis targets your thyroglobulin. Okay, so those are the most common. This is just an example of a graft transplant rejection. So this is an illustration wherein the green ones are the donor and the blue ones are the recipient. So basically, if there is an activation or direct killing of endothelial cells, we have direct killing of this. We have an acute rejection. Initially, there is after doing the transplant, your body recognizes this as foreign, so it attacks its transplanted organ for that matter. So that usually involves acute rejection, and then maybe in months and in years, there is what we know your chronic rejection. That is most commonly found in a transplant patient. Okay, so that's why HLA typing during initial screening and evaluation of donor recipient are very important. Okay, I think this will be the last topic. What's the biochemical basis of immunodeficiency states as we are talking immunochemistry? Immunodeficiency can occur in of the 4 major components, like the B cell, your T cells, or sometimes can be both B and T cells, your complements, and your phagocytes. So these deficiencies can be either congenital or acquired. No? All right. Being immune deficient or immunocompromised, recurrent or opportunistic infections such as your fungal infections are commonly seen. So not just fungal, you can also acquire parasitic or bacterial infection. Okay. So first, let's discuss an important congenital immunodeficiencies affecting your B cell. No, an example of which is your Bruton's agamaglobulinemia. This is actually an X-linked recessive, wherein the defect is in the tyrosine kinase gene. Okay, the clinical features, basically you will notice the clinical features of these immunodeficiencies are actually recurrent bacterial infection. As mentioned, you are immunodeficient, you are immunocompromised, meaning compromised immune system. So expect that the ones that we have talked about in defending this microorganism using our immune system is really compromised. So there will be no production of antibodies, no T cell, B cell, etc. Okay. Now in B cell, Bruton's agamaglobulinemia, there's defect in tyrosine kinase. Let's go now to your T cell. Your T cell involves your thymic aplasia. As you all know, T cell are differentiated and matured in the thymus. Thymic aplasia meaning you don't have thymus, as well as your parathyroids. The molecular defect of which is actually genetics. Now there is a failure of the development of your third and your fourth pharyngeal pouch. This is also known as your DiGeorge syndrome. Clinical features would include a recurrent viral, fungal, protozoal infection. And if you notice, if there is a parathyroid underdeveloped, if you have an underdeveloped parathyroid, as you all know, parathyroid is important in balance of calcium in our serum or in our body, thus producing hypocalcemic tetany. So ibig sabihin, you have a decreased calcium level in your blood producing tetany. Okay? Another T cell defect would be the chronic mucocutaneous candidiasis. Its molecular defect is a non. Its clinical features would include, as the name implied, candida, meaning a fungal infection with candida albicans, and you have a mucocutaneous involving your skin and your mucous membrane. Okay, what are the defect or immunodeficiency state when there is a combined B and T cell? Wiskott-Aldrich syndrome, its mechanism is actually unknown, but look at the clinical features of this B and T, no combined immune deficiency state. They have recurrent bacterial infection. But take note of this, Wiskott-Aldrich syndrome, it's unknown. Your chronic granulomatous disease or CGD, its molecular defect is NADPH oxidase deficiency, whereas your severe combined immune deficiency or SCID, its molecular defect is the enzyme adenosine deaminase. Okay. All right. And lastly, your defect is at the complement system. You have your hereditary angioedema. If you have a deficiency in C1 inhibitor, you will develop hereditary angioedema. So there will be inflammation, right? So the clinical features is actually laryngeal edema. Generally speaking, if you have an inflammation, not just in the skin, but also inside, especially if you have laryngeal edema, airway is compromised. Thus, if you have inflammation, one of the management is anti-inflammation in a form of a steroid. Now, steroids are used or they are administered via intravenously so as to produce an immediate or an action or effect that is anti-inflammation. No? The airway is compromised, you have laryngeal edema, so much more for hypersensitivity reaction. So the management for hypersensitivity reaction is not just the antihistamine injection through muscle, but also we recommend the use of hydrocortisone or steroid injection via intravenous for a faster relief, for us to prevent anaphylactic shock or airway is compromised. Okay, and that's the end of the discussion.